The pursuit of better outcomes, especially in really complex fields like surgery, well, it's relentless, isn't it?
Absolutely. It's a world where every single detail can matter profoundly.
An improvement can literally save lives. So today, we're doing a deep dive into this really quite extraordinary story out of Michigan.
Mm.
It's about a unique regional collaborative that dramatically improved surgical quality right across the state.
Yeah, I found this fascinating.
What really struck me was how they seemed to crack the code on quality improvement. That whole systematic process of enhancing outcomes.
Right.
And they found insights that, well, they kind of defy conventional wisdom.
They really do.
So our mission for this deep dive is basically to unpack this model, look at its successes, which were significant, and explore these unexpected insights from the Michigan Surgical Quality Collaborative, or MSQC,
MSQC, yeah.
and figure out what it can teach you about making real, tangible progress, really in any field. And it's amazing, the groundwork for this kind of really rigorous outcome analysis was actually laid, a century ago by E.A. Codman.
That far back, yeah. His vision of meticulously recording surgical results.
It was, believe it or not, poorly received back then.
Yeah.
Way ahead of its time.
Completely. Then you fast forward to a more recent visionary figure, Shukri Khuri.
Right, Khuri. His vision for standardized national outcomes, which became the National Surgical Quality Improvement Program, or NSQIP.
That was warmly embraced, and it directly inspired the MSQC we're talking about today. It's such a powerful, evolving legacy, isn't it?
It really is. And that legacy, especially Khuri's emphasis on collegial interactions and building trust, that's a crucial piece of why this deep dive matters to you listening.
How so?
Well, understanding how these complex systems with all these different stakeholders can actually achieve significant quality improvements. It offers these genuine aha moments.
Okay.
It's about learning how things really get better, beyond just collecting piles of data.
Right. It's not just the numbers. Exactly. And this isn't just a story about surgery. It's really a blueprint for effective collaboration, for getting tangible results in pretty much any field that's facing information overload and needs measurable progress.
Okay, so with that historical context, let's dig into the MSQC itself. What is this collaborative at its core?
Well, fundamentally, it's this partnership. You've got the American College of Surgeons, ACS,
All right.
then 34 Michigan hospitals, and a really big private payer, Blue Cross Blue Shield Michigan, or BCBS MBCN.
Right, the Blues. And what truly sets it apart, and I think what we can really learn from, is this funding model. It's based on pay for participation.
Not pay for performance, which is the usual way.
Exactly. Think about that. Hospitals got funding for showing up, for engaging, not necessarily for hitting specific outcome targets immediately.
So how did that pay for participation actually work on the ground?
Well, the financial support, it was distributed using the standardized formula. It was based on the hospital's total BCBS and charges, right? And their active engagement in these collaborative QI efforts.
Okay, so participation was key.
Critically, it was not based on their outcomes. And to build trust, BCBS MBCN only ever saw aggregate de-identified data.
Ah, so no finger pointing.
None. No individual hospital performance was shared with the payer. That was, a game changer in what's usually a very competitive hospital environment.
You can imagine. And to make all that happen, they needed a pretty robust infrastructure, right?
Definitely.
The MSQC set up an administrative and analytics center based at the University of Michigan, and it was staffed properly. A project director, an executive committee, dedicated data analysts, even nurse coordinators.
Wow.
And interestingly, the hospitals involved were quite diverse. The majority, actually 62%, were community hospitals.
Not just the big academic centers.
Right, ranging from maybe 1,000 up to 10,000 general and vascular surgery cases a year. So real mix.
And what did they actually have to do to stay in the collaborative? What were the requirements?
Yeah, well, there was a clear set of expectations. They needed to submit their ACS-NS NSQIP data elements on time, respond to queries about the data,
Standard stuff.
cooperate with data audits, actively participate in the quality improvement efforts, and show they were actually using the performance reports they got back.
Okay, so use the data.
Crucially, they also had to share best practices and report on the impact of their own QI intervention.
The sharing part.
Yeah, and the IT structure behind it was pretty clever too. MSQC acted as this regional intermediary. It mirrored the national ACS NSQIP data flow, but it had its own server.
Why was that important?
It allowed for really rapid access to Michigan-specific data and the flexibility to keep MSQC-specific project data, which, turned out to be key for those special initiatives they ran later.
That makes sense. It's like having your own focused data set.
Exactly. Think of it like being a meticulous chef, weighing every single ingredient before a big service. It's that level of precision, but for people's health.
That infrastructure sounds incredibly solid. But getting so many diverse hospitals, especially community ones, to really buy into such rigorous data collection and sharing, what were the practical hurdles there?
That's a great question. Because that flexibility you mentioned certainly helped, but fostering that culture of sharing was paramount.
How did they do it?
Collaboration took multiple forms. They held these quarterly meetings at the BCBS and BCN headquarters.
Okay.
And these weren't small affairs. You're talking about 120 surgeon champions, clinical nurse reviewers, hospital administrators all in one room.
Wow. Okay.
And here's the really crucial part. Center-specific comparative data was provided, but confidentially. Meaning you'd see your hospital's performance data, maybe benchmarked against others, but you wouldn't know which other hospitals were which.
Oh, like a blind comparison that must take the pressure off.
Exactly. It really encourages participants who have specific problems to maybe go talk directly with centers that seem to have solved similar issues without that fear of judgment or, competitive disadvantage.
Yeah. That anonymity seems vital. But it couldn't just be meetings, right?
No. Beyond the in-person stuff, they really embraced electronic communication tools. They had the MSQC website, msqc.org, which became a hub for best practices, manuscripts,
Okay.
a hard copy newsletter too, and even more recently, a YouTube site.
Multi-channel approach.
Yeah, and this diverse communication strategy feeds right back into that pay-for-participation model.
Oh, so.
By dialing down the competitiveness, it genuinely fostered collegiality. It enabled really transparent sharing of both good and, importantly, the bad information, the areas needing improvement.
And that connects back to Khuri.
Absolutely. Shukri Khuri's original emphasis on those collegial interactions and building trust was foundational. It even extended to specific agreements, like no public bragging about good results.
Really?
Yeah, and an inclusive authorship policy for any publications based on the collaborative's work. Everyone who contributed got credit.
That's quite something. This commitment to collaboration, it sounds great.
Yeah.
But did it actually, deliver tangible results?
Oh, absolutely. The overall finding is pretty clear. MSQC's regional structure significantly accelerated the pace of surgical QI compared to non-MSQC hospitals. That's been reported elsewhere.
How did they structure that improvement process?
They followed a pretty systematic 6-step process. First, identify and bring in interested hospitals.
Okay.
Then implement the ACS NSQIP data collection. Third, measure the variation in outcomes.
Find the gaps.
Right. Fourth, identify the best performers for specific things. Fifth, figure out the best practices from those performers.
Learn from the best.
And finally, step 6, distribute that information effectively to everyone else.
Makes sense.
And they were also able to launch these really targeted deep dives into specific procedures, which really shows off that flexibility we talked about.
Like what?
Well, the colectomy initiative, for instance, MSQC developed procedure-specific complication data points. I think it was 19 data points for 4 specific CPT codes.
CPT codes being the standard classification codes for procedures.
Exactly. This went way beyond the generic NSQIP data. 22 hospitals participated. They entered over 2,000 cases. It just demonstrates MSQC's ability to innovate and go deeper when needed.
Any other examples?
Yeah, there was the myocardial ischemia initiative. That's heart complications after surgery.
Right.
20 MSQC hospitals added extra pre- and post-operative data elements. The goal there was to reduce variations in using expensive diagnostic tech and develop some evidence-based recommendations.
So these specific initiatives really highlight the power of customizing data collection for targeted improvement.
Precisely.
Now, as they were pursuing all this improvement, MSQC introduced what seems like a logical next step, the Big 10 process measures.
Ah, yes, the Big 10.
These were 10 clear, importantly suggested, not mandated strategic areas. Things like avoiding blood transfusions, maintaining normal thermia.
Keeping the patient's body temperature stable.
Right. And tight glycemic control, managing blood sugar levels meticulously.
You'd think, okay, here are the answers. Implement these 10 things.
Exactly. You'd think, finally, the silver bullet. But here's where the story takes this really unexpected turn. It reveals something quite profound about how change actually happens.
What did they find?
Well, what's really surprising is that while, yes, more of the Big Ten measures were implemented over time,
Okay.
initial adoption was actually pretty low. And this is where it gets fascinating, almost contradictory. The data just didn't definitively link those specific practices to the overall improvement they were seeing.
Wait, so implementing the Big Ten didn't directly correlate with the better outcomes?
It was hard to draw that direct line based on their analysis, which really challenges a lot of assumptions, doesn't it?
It absolutely does. So if those Big Ten weren't the main drivers, what was the active ingredient? How did they figure out what was really moving the needle?
That's where the power of those detailed insights, uncovered through their collaborative structure, really shines. The Surgical Site Infection SSI Reduction Initiative is just a prime example of the why behind their overall success.
Okay, SSI, infections after surgery, big problem.
Huge. And initially, even with their efforts, the SSI reductions weren't statistically significant across the collaborative.
So what did they do?
They went on a site visit to a community hospital that was identified as a best performer, specifically for clean case SSIs.
Ah, digging into the best practices.
And what they found was just fascinating, not what you might expect.
Like what?
A really high percentage of cases were done using local anesthesia, not general. They had remarkably low nurse turnover.
Interesting.
Meticulous attention to reducing traffic in and out of the operating room, limiting nurse breaks during cases to the absolute minimum needed, and physically extremely large operating rooms.
Wow. Those are specific and maybe not easily replicable everywhere.
Some maybe not, but they were unique, often unrecognized process factors that were contributing to success. Things discovered through that regional QI process.
Insights that, would be incredibly hard to pick out from just looking at a broad national database.
Exactly. So from these findings, they developed 5 suggested best practices, specifically for SSI prevention.
Okay, what were they?
Things like using a specific skin prep called ChloroPrep, giving pre-op antibiotics based on patient weight, redosing antibiotics during long surgeries, using impervious wound edge protectors.
Like a barrier.
Right. And avoiding blood transfusions if possible.
And how did they spread that knowledge?
Their dissemination methods were really innovative too. They created a brochure, sure, but also this large laminated board. It was designed to be displayed right over the scrub sinks in the ORs.
Visible reminders.
And it even showed the hospital's own performance data right there, plus a binder filled with the supporting manuscripts and evidence.
So it was this combination of collaborative discovery and really practical dissemination that was the engine.
That's an incredible story, discovery. But, I mean, bringing those unrecognized things to scale, especially something maybe sensitive like reducing nurse breaks. Well, how do they navigate the human element, potential resistance?
It's always the challenge, isn't it? It highlights that trust and collegiality really had to be there.
Yeah. So when you boil it all down, why did MSQC's regional model succeed so well? Several things stand out, right?
Definitely. First, that flexibility. Having rapid access to their own data, the ability to innovate with custom initiatives like the Colectomy project.
Crucial. Second, the detailed insights.
Yeah.
Being able to uncover those nuanced best practices, like the SSI example that bigger databases just miss.
Third, the accelerated pace. Faster data feedback loops and more frequent face-to-face interactions compared to a national program.
And finally, maybe most importantly,
Collegiality. That foundational trust, the reduced competitiveness fostered by Khuri's legacy, and that really smart pay-for-participation model.
it's a powerful combination.
And what's truly striking here, I think, is how this model goes way beyond just surgical quality.
How so?
It demonstrates that real sustained quality improvement often comes from these diverse, sometimes completely unrecognized process measures.
The things you don't expect.
Exactly. And they're discovered through open, trusted, localized collaboration, connecting this to the bigger picture for you, the listener. In this world just flooded with information, critical thinking is absolutely essential. This deep dive really shows that sometimes the secret sauce isn't some single mandated process pushed from the top down.
Right.
It's a dynamic, flexible system that enables collaborative discovery. It's about empowering the people closest to the work to find solutions together.
So as you reflect on this MSQC model, maybe consider how it challenges those conventional ideas about how large-scale quality improvement usually happens.
Yeah.
What if the key to unlocking better outcomes isn't always those top-down mandates, but actually fostering these trusted, agile communities that prioritize collective discovery over just competitive performance.
It's a powerful thought. We'd invite you to think about how these principles, that idea of pay for participation, confidential data sharing, rapid feedback, those deep dive site visits for nuanced insights, how could they be applied in your own areas of interest?
Whether that's professional or even personal.
Absolutely. How could you use them to drive meaningful change? Maybe the path to improvement really is through trusting and empowering the people doing the work.